Good morning, everybody. Whoa, there's a lot of people out there. How are you? My name is Bill Andrews. Some of you will know me. I'm a troublemaker. I like to ask all the awkward questions, and I like to dig deep into the nitty-gritty. And when somebody says they think they know something, I always like to say, are you sure? How are you going to show me that? And so we're going to go on a little journey now to try to understand. You know in The Godfather 2, when Michael Corleone says, I learned one thing from my father. Keep your friends close and your enemies closer. So I think if we try to understand, we've heard a bit this morning already about nice guidelines, etc. So we'll go on a little bit of a journey here together. So I was asked to speak about research and statistics. Well, that's enough to send anybody into a coma immediately, isn't it? So here's the title I was given, PTSD, Treatment, the Facts, Outcomes of Therapy. Okay, so who am I? Well, we started off several years ago starting a research network. This was a sort of a bottom-up attempt to try to understand what's going on out there in the field, and this came under the name the Human Givens Institute Practice Research Network, and I now don't know why my thing is not
something's fallen off somewhere. Would you get your memory stick and I'll tell a joke?
Oh dear me.
Bill's going to get his memory stick because this isn't quite working as planned. I'm going to tell you, being a Sussex boy, it's not so easy coming to London. You've got to get up early, you've got to have breakfast very early, you've got to get on the train, and some of us never do it. I met our postman once at the top of the drive, and he saw I was in a terrible hurry, and he said, what are you doing? I said, well, I'm in a terrible hurry, I've got to get to London. He said, oh, London. I went there once. Didn't like it. It was an operator, straight off. It'll run off the memory stick. Our next door neighbour went to London once for the countryside march. He got into an argument with the policeman outside Downing Street because the policeman wouldn't let him go in through the gates to go and see the Prime Minister. The argument got sufficiently heated that eventually the police made him turn out his pockets. In his pockets he had an enormous knife, a great big flint knife, you know, the sort of thing farmers might carry around. The policeman said, what are you doing? You can't carry a knife like that in London. And our neighbour said, well, what am I going to do if I find a sheep stuck in a hedge then? Anyway, enough of that. Fingers crossed. Oh, don't panic though. Whatever you do, don't panic. The important thing is not to panic. Stay calm.
Maybe.
Okay. Can we get to the beginning? I don't know. How do we get to the beginning?
Up there.
That looks much more promising.
Yeah.
Look at that. Something happened. The graphics dropped off.
Oh dear me. Okay, we're ready to go. Right. Take 2. PTSD treatment, the facts, outcomes of therapy. That's better. Okay, so as I was saying, we've now sort of expanded the network to widen the umbrella, if you like, and taken on a new title. I'm also part of the Centre for Clinical Excellence, which is an international consortium looking at trying to understand excellence in therapy, really, trying to learn from practitioners out in the field, the other end of the spectrum, if you like, to the sort of top-down evidence-based stuff. Now, we're talking about PTSD. I understand where Tony pointed out about post-traumatic stress conditions, but let's remind ourselves exactly what PTSD is according to the DSM. So there are 6 criteria. First of all, there has to be an event or events witnessed where there's threatened death or physical injury, and the individual's response has got to have been intense fear, helplessness, or horror. The second point is that there has to be re-experiencing with intrusive thoughts, distressing dreams, etc. The third point is that there has to be persistent avoidance of stimuli associated with the event or the events. The fourth point is elevated arousal that was not present prior to the events. That's an important distinction that has to be made. The fifth point is that the symptoms must persist for at least a month. And the sixth point, which is probably the greatest reason that people fail to be diagnosed with PTSD, is that the disturbance must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Now, you cannot be said to have PTSD if you're having a bad game of golf because you've had an argument with somebody at the golf club. And believe you me, I have heard people being labelled as suffering from PTSD in such a situation. That is not PTSD. PTSD is a serious business. To end up with a diagnosis of PTSD is a serious business indeed. However, psychological trauma is easier to conceptualize as a continuum. So, yes, you know, when we're exposed to difficult traumatic events, we get this physiological arousal. It was quite traumatic sitting there waiting to come up to speak here. I could feel the arousal, the adrenaline pumping in my system. But hopefully I won't end up with PTSD from that. But there's everything along the way: acute stress disorder, anxiety, depression, etc. And as you can see from what Pierce was talking about, that this is a continuum. And so people can present with all sorts of problems in relation to exposure to some sort of traumatic event. So it's a question then of, well, where's the dividing line between what you would say is a normal sort of reaction and what becomes something imposing in one's life and dysfunctional. Now, research and statistics, as I say, enough to send anyone to sleep. Look, if we're going to talk about research, we have to look at the scientific method. We have to understand the operating paradigm in which we are functioning at the moment. In the UK context, you've already heard mentioned several times about NICE guidelines. So let's try to understand what is going on in NICE guidelines. Well, the first thing you have to understand, it's critical to understand, is that the highest level of evidence as it stands today, February the 5th, 2011, remains the class A of evidence. The gold standard is at least one randomized trial, or let's see how this works, or meta-analysis of randomized trials. Okay, so that is the top level of evidence. That is the evidence that you need to get into NICE guidelines. Whether you like it or not, whether you disagree with it or not. No. So there's an evidence hierarchy which relies on the RCT, or meta-analysis of RCTs. Meta-analysis simply means where you aggregate a lot of data from lots of different studies. It's a little bit similar to the FTSE 100, made up of 100 companies, and they have different powers within the index. So in the same way, you could have an analysis of lots of different studies. The idea is to iron out the differences so that no one study is deemed to be too dominant in the results. Okay, so let's look at some interesting meta-analysis of risk factors. So back in 2000, Professor Bruin from London, Bruin, Andrews and Valentine, I hasten to say not this Andrews, looked at all of the research papers going back over the previous 20 years since PTSD entered the literature in 1980 to see if they could derive prediction factors of what would be most likely to suggest that people might suffer PTSD. So here's looking at it in a bit more detail. So as you see over on the right, these ones top the list. And the one in the middle, the tallest one there, is lack of social support. So let's just list these. The top predictor of whether somebody is going to end up with PTSD following exposure to trauma and all those those 6 criteria is lack of social support. The second strongest predictor is post-trauma life stress. So what's going on in their lives after the trauma has actually occurred. And the third strongest predictor is the actual severity of the original incident itself. But standing head and shoulders above the rest is lack of social support. Let's look at NICE guidelines very closely. 2005 is the last guideline produced on PTSD. And the message is very, very clear. You won't be able to read it from the back, but it's trauma-focused CBT and EMDR. So eye movement reprocessing. So let's look at this in a bit more detail. What is trauma-focused treatment? You see, what's interesting is it's a whole umbrella of different things. You know, the trouble with guidelines is that people read the front page. Nobody takes the trouble, except nerds like myself, to go digging deep into the data to try to find out, well, what do they mean by trauma-focused treatment? Well, this is what they mean. They mean prolonged exposure, image habituation training, imaginal flooding with implosive flooding therapy, imaginal exposure and biofeedback-assisted desensitization treatment, cognitive reprocessing therapy, cognitive restructuring plus exposure, cognitive trauma therapy, brief eclectic therapy with elements of psychodynamic therapy. Give me a break. There's a lot of stuff in there. That's a very, very big umbrella. When you start looking at these, if you look at these treatments in detail, you see that some of them are like 1,000,000 miles away from the other ones. And you think, well, how on earth did this happen? So what the umbrella of trauma-focused treatment is actually a very, very large umbrella indeed. Now, you might say, well, okay, let's look at the studies that have informed these guidelines. Well, there's a whole clatter of meta-analytic studies. Remember, this is the top level of evidence. 2007, 2009, you see very, very recent, all these were done. Now here's the interesting finding about all of these trauma-focused treatments. This is published by the people who did the studies. The common focus, in agreement across the field, is that the focus is on traumatic memories and the personal meaning of the trauma. But here's the critical thing to understand. There's no difference between any of these trauma-focused treatments. So in the literature, you may find lots of evidence for a study saying that this treatment seems to work better than nothing, better than weightless control. But as soon as you compare this treatment on a trauma-focused type with another trauma-focused type, and you look at all of the studies, there's no difference in the outcomes. You can't predict which way of working is likely to give a better result. Okay. So then a guy comes along from the University of Madison called Beanish, and he says, actually, there's no difference in outcomes between any bona fide treatments, whether trauma-focused or not. Well, this really shook the world. It was time to get the gloves off. So, we had these heavyweights, these academic heavyweights, outraged with each other's findings. So, you know, these were the heavyweights fighting the battle odds. So, the guys who'd written all the trauma-focused treatment papers said, you can't say that. You've included studies in here and you've excluded studies on this and that and other criteria. They fought back again and they said, no, hold on a minute. Your criteria are all wrong. And actually, in this 40-page document, we will take apart your criticisms point by point by point to say that actually the way you're presenting evidence is unfair. You're including, for example, just one simple example, saying that treatment X, a trauma-focused treatment, is better than treatment Y, a non-trauma-focused treatment. But when you look at treatment Y, you find it's not actually a real treatment at all. What it is therapists who are not allowed, they're proscribed from engaging with the natural things that people want to talk about in the treatment. So it's artificially manufactured, supposedly to control for what's called common factors. This means that it's very, very confusing. Now, this is what's informing NICE guidelines. But people don't really understand this, that there's this, at the highest level, this debate. Now, to me, this is what it's like. It's about, you know, whose cooking do you like? Do you prefer Jamie Oliver, or do you prefer the mad guy in the middle, you know? Well, it seems to me it's down to personal preference. And you know, what you want to do is come up with an Irish solution. So the Irish solution is, what you do is you make a load of grub, and you feed it out to the people, and you ask them, what do they think? And whichever they say they like, you put it in the cookbook, and you get the Avoca cookbook. Now that seems to me very sensible. I mean, what a concept, to ask the people that you're actually working with, or feeding, or whatever it is you might be, to get their feedback on what it is. Well, I would say that that is a pragmatic approach, that is what's sensible. It's down to earth, it just makes sense. If you are working with a bunch of clients and you ask them about your interactions with them and about their way of work, their sense of what's happening, then it seems to be a good approach. So that really is the basis of setting up a practice research network in the first place. And as I say, we're moving on now to expand that out on a more international basis. So let's look at what happens when we ask some customers. So we've been gathering data now for 4 years. Some of us have been gathering it incredibly rigorously, and my humble thanks to all of those people who I have been driving demented for several years to contribute their data to help me to try to complete my MSc, which will finish one day soon, on psychological trauma. So we have a data set where we measured people with lots of different measures. Core 34, the 34 question measure. Core 10, the 10 questions embedded in the Core 34. ORS, outcome rating scale, a 4 question measure. and the impact of events extended scale. Now, so these are like measured to death, for God's sake. You know, we've asked them so many different questions in so many different ways to try to really understand. Now, I hope you notice that there's a difference between the length of the two blues on each of these diagrams. So the befores, the afters. Now, let's see who's awake. Who can spot the anomaly?
ORS. Yeah.
Okay, well, the reason is because with the ORS, as you get better, the scales go up. So that's why it's inverted compared to the other ones. But basically, I hope you can see that regardless of how you measure these people, that something has happened in the treatment. They've changed. Something has happened. Now, there's something called an effect size. An effect size is talking about the magnitude of the change. The effect of the treatment. Was it a little bit or a good bit? Basically, this is a hell of a good bit. In fact, if you put a line up there, which is what you typically see from effect sizes from very well conducted randomized trials, that is the sort of effect size you see. So the effect size of these treatments appears to have been very, very high. In fact, regardless of the measure, this is the other interesting thing, that whichever measure you look at, even the most conservative effect size here is 1.8, which is very high. I mean, if you can show an effect size of 1, it means really quite a lot. If you're showing effect sizes of 2, that's huge. That's a very big effect. So something is going on in the treatment of these people, 130 people. Okay, so then of course what I have to do is go and stand in the mirror and argue with myself and say, well, yeah, but hold on a minute, Bill. How do we know that those people were really distressed? So the guy in the mirror says, well, I'll tell you what, let's get rid of all the ones who weren't incredibly high on the distress measures. So let's narrow them down to 44. Now, so I've taken 44 of those 130 people who were incredibly distressed. They were all in the severely distressed category on core, scoring an average of 24 out of 40. That's very, very high indeed. And let's look at their scores. Well, here we are looking at every single one of these were measured with the impact of events as well. And you see a very large effect with the impact of events. You see a very large effect with core 34. So the fact that we were looking at a cohort that was very, very distressed is still showing a very large improvement in treatment. And in fact, we're looking at the cutoffs on the measures there, and you can see that after cutoff on these 44 cases, this is a mixture of clients from several therapists around the country working with psychological trauma. Many of these clients have been in serious road traffic accidents. They've been involved in muggings or attackings or abuse of one sort or another, or indeed are war veterans. So it's a wide mixture of trauma, really. So, okay, so then you say, well, okay, let's take some of the evidence from the NICE guidelines informed treatments. Now, one of the most important studies, which is very related to the subject of the topic today, is from Northern Ireland by Duffy et al. And this is where a treatment designed by David Clark, cognitive behavioural, trauma-focused cognitive behavioural treatment, was used. And they used different measures to what we use. So how can we make a comparison? Well, one of the measures they used was the Beck Depression Index, a well-known measure of depression. And some years ago, a paper was published to convert the Beck Depression Index to core, so that you could say, if you measure in Beck, you can also do a little calculation and you get the figure in core. So I did those calculations, and these are the results on their 47 cases, with an average intake score on core of 24 and exiting at 17. And then if you put that up next to our 44, average intake of 24, average exit at just under 10. So it's pretty striking, and it's incredibly encouraging. So whatever the heck it is that those therapists out there are doing, that are measuring in this way, is clearly having a large effect. So looking at the differences between the cutoffs, you can see that from the study in Northern Ireland, they didn't end up below the cutoff on the core, but these 44 did. So that is a very, very encouraging. Now, going back to the predictors of PTSD, if it is true that lack of social support, post-trauma life stress and trauma severity are predictors, well, it would make sense then that predictors of PTSD resolution would be the opposite of that, surely. That recognizing the importance of social support would be important, teaching skills for management of post-trauma life stress, using effective techniques to help de-traumatize the trauma, and then most of all, to be guided by the service users that we're trying to help to find out, well, look, you know, is this acceptable, this way of working with you? Does it make sense to you? Are you getting something out of it? That seems such an obvious thing to ask. Now, you know what? You can have it whichever way you want. If you want to be trauma-focused and say there's no difference between treatments, fair enough. If you want to controversially look at the business study and say, well, actually, there's no difference between any treatments and it's hard to know what's trauma-focused anyway because there's this whole great big list, you can have that. But, you know, what about? Where can we find the common language? Where can we say, look, everybody agrees about this? Possible factors that seem to be important in successful treatment for post-traumatic stress disorder. Now, I ask you, we have lots of therapists in the room, and we may have some service users in the room as well. So I ask you to think about how many of these boxes you feel comfortable that if you were a service user were ticked off in your treatment, if you're a therapist that you can tick off. Okay, so first of all, you have to have a cogent rationale that's acceptable to the patient. You've got some explanation of what's going on about their experience that makes sense to them. Secondly, that you have a set of treatment actions that are consistent with that rationale. Thirdly, that you develop and monitor a safe, respectful and trusting therapeutic relationship. Fourthly, you agree about tasks and the goals of therapy. So you've got an agreement between you, the therapist, and the client about, look, what is the point of all this? What's the direction of travel? You nurture hope. You identify patient resources, client resources, service user resources, strengths, survival skills, intra and interpersonal skills, and building resilience is clearly very, very important. Now, this is agreed by everybody in the field. This is not something that there's dispute over. Everybody can sign up to this. So I ask you to think. Education about PTSD, offering explanation to people about their experience. Giving people, if they so wish, an opportunity to talk about the trauma. In many of these studies where there were head-to-head comparisons, in the control group, the clients were not allowed to talk about the trauma if they wanted to do so. They were actually stopped from talking about it. Well, that's ridiculous. No therapist would want to carry on like this. Ensuring the patient's safety, especially if the patient is being victimized, subject to domestic violence or abuse. Helping patients learn how to avoid re-victimization so they don't go back into that very difficult situation. Fostering independence and self-efficacy. Seems to me, one of my latest mentors is a chap called Dan Fishman. And I really like what he has to say because he talks about this argument going on about this positivist view that NICE Guidelines is informed by at the moment, on the one hand, and then the postmodernists on the other side saying, no, you can't measure anything, you know, it's all about this sort of woofy stuff. That doesn't work. He says, look, come down from the lofty perch of ideological purity. Pragmatism meets the world as we find it and says, how can we improve it? Not in some ideal way with a predetermined endpoint, but in a practical way in the here and now, within a context of the social, cultural, political, and economic realities we are given. Now, we had an outline of those certainly political realities at the beginning of the day. So what we have to do, you know, we have to work with it. We've got to say, this is how it is, what can we do in this context? So it seems to me that taking a pragmatic approach to this then will put the service user at the top of the agenda. You will certainly hear from me that there is no way out of this second one. You must gather robust pre-post data with internationally recognized self-report measures. There is just no room in our field for not measuring anymore. It simply makes no sense. Then you benchmark your results against published data. This is what we're in the process of doing now. And to cover for the allegiance factors, I've got together with an international team. So I've got people who have no affiliation or association with our way of working to investigate the data completely independently of me and benchmark it against already published data. And I would describe the way that the therapists who are informing both PTSD resolution and have informed my research work as an innovative treatment. So it makes sense to map the innovative treatment onto existing approved treatments. You can see under that CBT umbrella, there's a wide range of treatments. Well, there are many elements within that wide umbrella that actually map perfectly well onto what we are doing. Strongly, I believe, is the case for carrying out case study research to elaborate on the features of particular treatments from multiple perspectives. So this is to get a sense. I feel that the last 4 years we've gathered a lot of what I would describe as macro data. We've got a sense of lots of numbers now saying, look, you know, there's something going on. You look at 130 cases, something's going on in the treatment. What we really now need to figure out is what specifically is going on. What words are being shared? What are the client's perceptions of the treatment? How do they feel after procedures have been done with them? And that's really where we're going now. When funding allows, certainly carry out RCTs, but don't get hung up about RCTs. And hopefully there's going to be a shift beginning to take place. Now, Steve Holland, who's been one of the greatest advocates of RCTs since the 70s, said, you know, with respect to randomization, I would paraphrase Churchill on democracy, it's a terrible process that has little to recommend it, except that it's better than all the alternatives. Well, I suggest that there are alternatives, and in fact, a chap called Paul Salkowskis, a very highly respected cognitive behavioural therapist in the UK, talks about empirically grounded clinical interventions being informed from outcome research, from theory, from clinical practice and experimental studies, but no one taking hierarchy over the other. They're all part of that information process. And in fact, in 2002, long before the Improving Access to Psychological Therapies program came about, he was already concerned about the direction of travel of the evidence-based practice movement. And he said, you know, we're reductionist in our thinking, and it's becoming a parody, a kind of one-dimensional science, and that this is already happening in 2002. Well, 9 years later, it's certainly continuing. Professor Gordon Turnbull is the associate professor on the psychological trauma course that I'm participating in Chester University, and he's here at the Capio Nightingale in London. He is an ex-RAF man, and he has an incredible pedigree in the treatment of trauma. He was involved in Lockerbie, he was involved with Falklands veterans, he is involved with the hostages coming back from Beirut, and just a very, very experienced chap, a lovely man. And in fact, we were trying to get him to come along and speak today, but he was unable to make it. But I was in communication with him, and I said, you know, in the last few years, from what you're seeing, what do you feel, what's your opinion about significant breakthroughs in trauma treatment? And this is what he had to say, so I've just called this the new frontier, really. And he said, well, the literature now is really clearly telling us that it's unprocessed trauma memories control and cause the exaggerated function of the autonomic nervous system. And so he's saying, you know, PTSD is truly a mind-body experience. The post-traumatic stress conditions, the whole thing is, it's a mind-body. You can't separate this out. It's not just a psychological process. There's a lot going on in the body, and you have to be aware of that. In fact, going back to Bessel van der Kolk in the late 90s, wrote this wonderful paper, The Body Keeps the Score. And really, all of the evidence from all the latest neuroimaging studies, etc., is confirming that very much. And Gordon Turnbull is pointing out that there's now an emphasis shift to the more body-focused therapies. So he talks about sensoromotor therapy, EFT, emotional freedom technique, acupuncture, and acupressure, that these all have very significant roles to play. In fact, when I was over at Chester, he described EFT as the Heineken of therapies that reaches parts no other therapies can reach. So a very, very open mind indeed. And he says, you know, what we have to look for is ways of, and I love this, of soothing the chaos in the right hemisphere. EMDR, mindfulness are all areas that are getting lots of attention. And he sums up by saying, you know, using any treatment that works on soothing the autonomic nervous system and works on the right hemisphere is likely to be a good idea. So I ask yourselves to ask yourself, is your treatment for trauma, does it do these two cardinal things? Does it soothe the arousal in the autonomic nervous system, and does it work on the right hemisphere to help to process the unprocessed memories. Medications, there's a role for medications. Propranolol, lowering adrenaline, seems to be helpful if people get that in the acute stress reaction. It seems to reduce the etching of these emotionally charged memories. And opiate antagonists help to prevent dissociation, which is associated with endorphin flooding that takes place in the trauma experience. I actually think this second point is incredibly important. Avoidance. He says, avoidance is a key feature of PTSD, and dissociation commonly occurs at the time of the trauma, and so becomes an integral part of the flashback. Now this explains how difficult it is sometimes to actually access the emotional template, to awaken that template up in people, because they dissociate. It's not necessarily that they're on some spectrum of disorders that I've heard floating around about stuff like Asperger's and this sort of thing. Dissociation is probably far more significant as a common cause of treatment resistance. So even just going to see a trauma therapist is enough to make the endorphins pop, to have somebody dissociate. So my take-home message: have a healthy sense of curiosity. Have raised eyebrows about everything that you hear. Keep an open mind. Systematically reflect on your own work. And of course, it's far easier to systematically reflect on your work if you have data to reflect on. Take a balanced and informed view of the research. Familiarize yourself with it. Measure your outcomes. There's no getting away from it. Support research and/or get involved in case study research yourself. Be respectful of other modalities of treatment. All of the evidence to date where there's comparisons suggests that there's no difference in treatment outcomes. So we have to make a different sort of an argument. Trust your clients above all. You can find the latest information about what we're doing at a new blog we've just started, pragmaticresearchnetwork.blogspot.com, soon to be followed by a new website. Thank you very much for your time. I think I'm ending there.
Thank you, Bill.